Ask anything about bones and joints tonight on Call with the Prairie Doc. Funding for On Call with the Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information. And by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubach with Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, the Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with the Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation. The arm bone's connected to the wrist bone's connected to the hand bone's connected to the telephone bone. Telephone bone? Yes, it's time for you to call in your questions about bones and joints. We're on call with the Prairie Doc.
Good evening and welcome to On Call with the Prairie Doc. Tonight we have one of our favorite guests, Dr. Jim Engelbrecht. Dr. Engelbrecht is a rheumatologist at the Regional Medical Clinic in Rapid City. Rheumatology is a subspecialty in internal medicine and pediatrics devoted to diagnosis and therapy of clinical problems involving joints, soft tissues, autoimmune diseases, vasculitis, and heritable connective tissue disorders. We know that many of you will have questions about osteoporosis, arthritis, or other disorders of the bones and joints, so give us a call at 1-888-376-6225 or email your questions to ask@oncall.org, oncalltv.org, sorry. Welcome, Jim. It's just a pleasure to have you back. You've been our guest for we've been on the air. This is our 13th season. I bet you're on the air at least once or twice every year, and there's a reason for that.
It's certainly a privilege to be here, and I'm enjoy it every time we do it.
So you're from Rapid City, originally from Iowa.
Right, Lamar's.
We've got some Iowa people watching, I'm pretty sure.
Oh, I'm sure.
Yeah. So we appreciate that. We'd really love to have some Iowa calls. So we're talking about rheumatology. What is rheumatology?
Well, rheumatology, as you mentioned, is a subspecialty of internal medicine. I think a lot of people don't quite get that. To be a rheumatologist, you have to start with internal medicine. You have to do the basic internal medicine training. And then as the other medicine specialties are, such as cardiology or pulmonary or nephrology, rheumatology is one of those subspecialties where you do additional fellowship training for a couple of years and learn about what we call rheumatic diseases or arthritic diseases or diseases that manifest themselves with joint pain and swelling and therefore have sort of collectively become known as the rheumatologic diseases. So that's how you get there.
So immune system diseases, you share interest with the immune system with most specialties, but primarily with allergists and with dermatologists.
Well, and again, you're dealing with an immune system that has, for whatever reason, gone awry, and it either is overreacting or underreacting, producing antibodies or not producing the right antibodies that are attacking or disrupting your own tissue. And a lot of times that plays out in the joint, the tissue around the joint, so that's how the arthritis thing came. But the other thing is the skin. So we spend a lot of time talking to dermatologists. Another common area is the eye. We spend a lot of time talking to ophthalmologists. But any organ system really is fair game for this autoimmune disease entity.
And tell me a little bit about the changes that you've seen you started practicing in '82 or in rheumatology.
1980 in Rapid City, but if you look at the changes since I started medical school in the early '70s, it's just been unbelievable in rheumatology, the changes that we've seen. And
What's the biggest change that you've seen?
well, I think with rheumatoid arthritis, when I was in training, we basically taught people how to use intense anti-inflammatory medications, 14, 15, 16 aspirin a day. You cause all kinds of problems with that, but keep the inflammation down. Then we had drugs like Gold, that we were using Gold shots, and there was some anti-malarials, chloroquine and hydroxychloroquine, that were coming along. But depending on those drugs, we could not get a predictable response, and we always were dealing with toxicity. And then along came the whole thing with methotrexate, which interestingly I was involved with in the 1979, 1980 at the University of Utah, where I was. We started one of the first studies on rheumatoid arthritis using methotrexate. And I went back, I'd entered some patients in this study, and then I went into practice, and I went back the next year, and I went to the clinic where they were looking at these methotrexate patients, and I was stunned. I couldn't believe it. I went back to Rapid City immediately in the spring of 1981 and started using methotrexate for rheumatoid arthritis. It changed everything, okay? It changed the outcome of the disease. And then when we got the people that didn't respond, the biologics came along, and that really has developed in the last 15 years, which is a whole other area of intense treatment.
So I learned at a national meeting, internal medicine meeting, that 50–60% of the rheumatoid arthritis, the severe illness of debilitating arthritis, can be controlled with methotrexate, and the others have to go to biologics. And
right.
Is that where you're at?
That's true, yeah. Well, and I would say it's even more than that in our experience. I think it's a matter of, it's one thing to say the drug, it's another thing to really know how to use it and have the experience with it. And when you go back, literally 35 years I've been using this drug, you pretty much know how to get the most out of it, how to manipulate it or whatever.
And what does it do? I mean, it's not very expensive as compared to the biologics.
Oh, yeah.
What does it actually do?
Well,
It
it disrupts the immune system. You have the production of these antibodies or other proteins that cause the inflammation, that cause the destructive disease to the joints. And what it does at a very fundamental biochemical level, it disrupts the production of that. We could go into the disrupting the purine based synthesis of but it disrupts the immune system, and that's what it does. And it does it at a low enough dose that it's otherwise safe. Methotrexate was originally developed to treat leukemia in kids, okay? Big doses, okay? And it's still used for leukemia in kids. Yeah. And then, along comes, gee, this kid's got psoriasis, and that was clearing up. And they said, gee, maybe this would work in psoriasis. And so in the 70s, they tested it in psoriasis. And a lot of people with psoriasis have arthritis. And gee, the arthritis was getting better, and all of a sudden it was being tested in rheumatoid arthritis. It's the way research works. It's the way things develop. Yeah.
Research, very important.
Very important research. And, we had talked about research and the fact that people, I think in South Dakota, don't realize how much research is going on.
Where?
In the various systems we have. Avera, Sanford, our regional system, we have a big research department. I mean, you can pick up the phone if you've got any of these conditions, from skin problems to infectious problems to oncology, whatever. Call the hospital system and ask for the research. Yeah, just ask for the research people, department. And you'd be amazed at the number of things we have going on. But that research has been incredible in the last 50 years.
All right. Our bones and joints are the superstructure of our body. They support all the organs and tissues of our various systems, giving muscles and tendons a place to pull against so we can move. Let's take a closer look inside the body at our bones and joints. Welcome to a walk through the anatomy of a marvelous movable joint. Note the bones of this joint and the opposing supportive muscles and the ligaments surrounding the joint that contract in one side while on the other opposite side they relax, making movement and movable yin and yang. Note the ends of the bone that are coated with the ultra-smooth, rubbery, and slightly giving cartilage, making a smooth surface with which to come in contact. But even more important, and another very necessary component of a movable joint, is the synovial sac that contains just the right amount of lubricating jelly to allow the bone and cartilage ends to glide over each other as the joint moves. Open a plastic baggie and place within a couple squirts of hand lotion. Express all the air and lock it closed, placing your hands on both sides and move it around. And there you have a facsimile of how slick a synovial sac can be. Now think about a lifetime of working the knee, hip, shoulder, or hand and finger joints. And the most interesting thing about these joints is that the worst thing for a normal joint is not to use it. We're not talking about abuse like in some ball players, but the old saying is so true: if you don't use it, you'll lose it. It is amazing what a normal joint can do. So call in your questions. We love them. 1-888-376-6225, or email your questions to oncalltv.org. So Jim, response to that, we were talking about synovial fluids. We did that Ziploc bag thing, and I mean...
Other than, I've never seen anybody refer to flexion and extension as yin and yang before.
Oh, yeah, okay.
That's pretty interesting. But the synovium, okay? The thing you did with the plastic bag,
Yeah.
okay? That is really critical to the autoimmune diseases, because this interaction of the antibodies attacking the system occurs in the synovium. And the synovium gets inflamed, it doesn't work right, and so that nice, smooth operating thing that you just showed there, that goes away. It gets filled with fluid. We get fluid in there. Sometimes you got to pull the fluid off, and it all is coming because the disease is really coming from a problem in the synovium. That's what the actual autoimmune disease. Now, the degenerative diseases, it starts in the cartilage. Okay, and so when you saw there, so the cartilage starts to break down, and then the bones respond to that, and they form spurs. You know, when you break a bone, what does it do? It forms a callus around it, right? Well, same thing. When you start wearing out that joint, it forms a callus called a bone spur. Okay, and so the degenerative process really is totally different than the synovial process. It's very interesting.
With most immune system arthritides, the arthritis of immune-driven arthritis is against the synovial system.
The process is in the synovium, yes.
And the synovium is that plastic baggie with the juice?
It is.
There it is. That's a great one.
It is.
Well,
and then it messes up the yin and yang.
And then the yin and the yang can't occur. We have a caller. Does smoking affect a back surgery recovery, and does it make it more painful?
Oh, let me tell you about cigarette smoking, okay? That's what's been studied is cigarette
Well,
smoking.
now, people think that doctors are against smoking.
Oh yeah, well, they are. So, okay, and but I'm just saying that if you look at recovery from spine surgery in cigarette smokers, it's terrible. They have the higher complication rate, they break down, they have resurgery rates higher, everything in terms of if you're going to have critical surgery on the back and you're a smoker, you basically have stacked the deck against yourself right from the beginning. The other thing, though, in rheumatology is that cigarette smoking clearly is associated with worsening rheumatoid arthritis, okay? It has been shown unequivocally in the studies that people that have rheumatoid arthritis that smoke cigarettes, now, it's, chewing tobacco, not so much, but cigarettes, okay? There's something about the cigarette that smoking that makes rheumatoid worse, and as I learned that, as I reflected on my own practice with that, I can see that in the patients I've taken care of who were smokers and non-smokers in terms of the difficulty in trying to treat their rheumatoid. I had no idea until the last few years that was really a relationship, but that's, yeah.
So my sense is that I know smokers who are great people, very moral, very caring, and people who are not smokers who aren't. I mean, it's not a moral issue.
No.
It's totally a health issue.
Right.
And if you can convince people to realize that, it's just a terrible habit to quit. Do you have any clues to helping people quit?
Just quit. You make a choice, you quit.
Yeah. How about osteoarthritis in smokers?
Not so much as in terms of the rheumatology side of it, but again, Complications from surgery. What's the most common surgery that the osteoarthritis patient has? Replace their knee, replace the hip. Look at the complication rate in the smokers in the hospital.
So the complication rate is how much higher?
Well, it's just higher in smokers across the board, no matter what the procedure is.
All right. Here is from Rapid City, Sjogren's syndrome. How does it affect joints, and what kind of deterioration does it cause? What is Sjogren's syndrome?
Sjogren's syndrome is an autoimmune disease. Okay, so we've got, again, something that's going out there, sort of working through the immune system. It tends to concentrate on some of the tissues in the tear glands and in the salivary glands, and so people very often early on will have dry eyes and dry mouth. And again, you know, when you live like in western South Dakota where the wind blows and the air is dry, we all have dry eyes and dry mouth a lot of the time. But this is really pathologic dryness, okay,
right,
that you can actually measure. You can actually do a test to measure how much tear production is. But then,
how much of that is alone? I mean, some of it's just eyes and parotids, and that's it.
And that's it, okay. And then, but then, like all autoimmune diseases, it tends to have tentacles, and it casts its it casts itself into other areas in joints. It can be vasculitis. It can get vessel inflammation. It can get into the lymph glands, cause some problems there. And so, you know, there again, you can get Sjogren's that has very limited disease, and you can have Sjogren's that can have widespread disease. We've even had Sjogren's people who have had neurologic problems. I mean, serious neurologic problems.
But still just Sjogren's. Now, is there not a Sjogren's-like syndrome that comes with lupus?
Yeah, you know, it's confusing. The dryness that can come with these other diseases is often referred to as Sjogren's, but sometimes it's just dryness, and sometimes it's real Sjogren's complement to the disease. And you can sort of make that demarcation by some blood tests that we do, some certain blood tests that are for Sjogren's. And the other thing is, if we really think, if we're really confused and we think somebody has real Sjogren's, we can do actually a lip biopsy and have and that'll show the particular kind of cell that we're looking for.
A specific antibody against the parotid saliva gland in the eye.
Yeah, there's an antibody. They're called Sjogren's antibodies. The Sjogren's precipitants. It's SSA and SSP.
Okay, so people can have a lot of dry mouth. I mean, I see tons of dry mouth.
That's a whole.
A lot of it's drug induced.
Yeah.
I mean,
and you know, it's better to call it dry mouth and dry eyes, okay, zero ophthalmologica or xerostomia or whatever, than calling it Sjogren's. If you say somebody is Sjogren's, you better have the proof, because you gotta have the serologic studies and or a biopsy or something,
okay,
because that's a vastly different deal.
And so it alone does not affect joints as a rule.
As a rule, but it can, yeah.
So now that's one rheumatologic disease that has a blood test that can confirm it or can support it.
Can support it.
All right.
Okay.
How many rheumatologic diseases have a blood test or an X-ray or a specific test, or how much of it is really made by clinical knowledge?
Well, it's a lot of clinical. The thing is that, you know, you tend to think, I mean, people for years would think of arthritis as one thing, okay? Yeah. Arthritis is hundreds of different things, okay? Hundreds of different diseases can have arthritis. The same with the blood test. You can have rheumatoid arthritis that has this test and that test positive, and that has a certain implication, or you can have it not have that one positive, but this one positive, and that has different implications. And so there's not the absolute. The closest we get to that is with lupus, where we can actually, in most cases, find the antibody called the DNA antibody,
and we can measure your own DNA.
Right. It's an antibody that goes after DNA, and we can measure that, and we can monitor that, and we can get a sense of what's going on. That's probably the closest.
You know, that really scares me, because I know that there's a myriad of different ways lupus can present itself, but it's an antibody against your own DNA. Well, every cell has a DNA.
Right. That's right. Well, that's why lupus is basically, you know, stem to stern. I mean, everything from the skin to the blood and everything in between. I mean, from CNS tissue, nervous, you know, your brain to your blood to your kidneys to your joints to your skin. But the good news is it doesn't do that to everybody. Okay.
Yeah.
It has different ways of doing this, and the even better news is these sort of widespread, system-wide, you know, destructive things with lupus are really a really small part of it. Okay, but there again, the prognosis for lupus has changed dramatically over the years.
We're treating with methotrexate.
We're treating some of it with methotrexate. There's some old drugs that we know how to use better. I think the important thing with lupus is that we can get to a diagnosis quicker. We can manage the complications better. We got better antibiotics. We got better this, that, the other thing to support that person. We've got better medications. We're using medications earlier, and the prognosis has just flipped from 1960, where the 10-year or the 5-year survival rate of lupus was in the neighborhood of 10%. Now the 5 and 10-year survival rate is almost the same as the normal population.
Wow. I mean, we've watched that happen.
Yeah.
Because of people like you.
Well,
You know?
well.
Here is a question: is my arthritis going to keep getting worse? Start in my pinky and has moved. Anything we can take for arthritis? So I think this must be osteoarthritis. Started in the hands.
Yeah, if it starts in the the arthritis, different arthritic conditions have different patterns that we look at. And a lot of the osteoarthritis will start in what we call the distal interphalangeal joints, which is probably what's going on there. You notice a knob here or a knob there, and it gets sore or whatever. That's usually the start of osteoarthritis.
Okay. So, and what do we do for it? I mean, what can we do for plain old garden variety osteoarthritis?
If you have the sort of primary osteoarthritis that's running through families, that's going to put knobs on your fingers and get your knees and and your hips and all that kind of stuff, there really is not a lot you can stop that. There's not a lot to do to stop that. But one of the things we think is controlling the inflammation, so using anti-inflammatory meds carefully but judiciously to keep the inflammation down, moving the joints, keeping them moving. We talk a lot when the patients with osteoarthritis. I mean, it's with rheumatoid. If your hands are involved, I can give you a drug that can get you remission. You can go back to playing the violin. Okay.
Right.
Osteoarthritis, you can't do that. But we talk about keeping the inflammation down. When they're warm, when you've got them in warm water, you flatten them out. You use
Keep them moving.
you use one hand to sort of, you don't hurt yourself, but you want to use one hand to exercise, the other hand, to move these things, but keep them moving.
You got to keep moving. I never could play the violin, though. I want you to know.
Well, listen, I could give you Enbrel and you could start
and I could start playing.
That's right.
So, why do statin drugs cause so much joint pain? Very interesting.
Well, it's actually more muscle pain than joint pain with the
Okay.
statins, and it's more muscle aches and pains. And it's probably, if you look realistically at it, it's probably in the 10, 15, 20% of people will have a problem with it, And some of them can be really severe. I mean, the 1 or 2% can get some real muscle damage. But it's because so darn many people have taken statins. That's part of the problem, I mean, everybody takes a statin. If you have something that's going to have 15 or 20%, so that's 1 out of 5 people taking statins. You got
1 out of 5.
100,000 people. There's a lot of people complaining of aches and pains.
What about if one statin is going to be more hard on than another? I mean, do you know about the different statins, and have you heard all that?
I think if you've had a bad reaction with one statin, the chances are you're going to have a bad reaction with all of them.
Yeah, that's where I'm at. What causes autoimmune disease? Genetics, age. What is autoimmune disease? Why does it happen?
No. It is a combination of probably some genetic predisposition. So there's probably something that is
in your family,
in the family, something in the genes, and it has set the immune system in certain ways, and it gets exposed to the right thing at the right time, at any time in your life, and all of a sudden something abnormal happens. Sets this reaction off, and the studying all the time, trying to figure out what it is that sets that off, and we don't know what it is that sets that off.
Our allergists talk a lot about hygiene theory, that they said that immune diseases have risen at the same time that everything is getting cleaner and the dirt is decreasing, and the immune system has to do with kids not playing in the dirt in their early ages. What do you think of that?
I'm not.
You're not going to make it.
I'm not going there with that. I don't know. I don't know the answer to that one.
Here's a caller. Catcher for a softball for almost 6 years. She's 20 years of age, and when the weather changes, her knees ache. Well, the weather changes. What do you think of weather and joint?
Well, there is something to that. It doesn't cause arthritis, but if you have a problem with the joint, if you think about it, the inside of your body and the inside, inside of your little plastic bag you were talking about, the inside of that joint, that has to equilibrate to whatever the barometric pressure is on the outside.
Yeah.
Okay, so the outside of your body's got to equilibrate with the inside of your body. When you get these rapid pressure changes, okay, you're start adapting out here right away, but it takes a while for that to translate. And so you've got a joint that's a little bit on the sick side, or maybe overused a little bit, or whatever. You start to feel those weather changes.
It's a real thing.
And, you know, I've had people say repeatedly over the my career, people saying, "Oh, I can tell, my arthritis is worse when the wind is blowing." Well, when the wind is blowing? What's that telling you? That's
the barometric
pressure change. So.
What is this catcher? She's 20. Is she going to have?
I suspect that's probably not an arthritis thing. That's probably a little bit of overuse. Young people tend to have a little problem with the kneecap, the patella. Sometimes it doesn't seat exactly right, and boy, when you're a catcher, you're stressing that out. And so my sense is there that she might have had a little bit of an injury to the underside of the kneecap, and there's names, there's chondromalacia, and there's things that can go on there. And if that continues, that should be looked at, because there are some things that can be done for that.
Play second base instead. Yeah. Surgery is an option for people with arthritis that doesn't respond to more conventional, minimally invasive treatments. For these people, a hip replacement can help them regain their mobility without a lifetime of pain. In the case we're about to see, arthritis caused the deterioration of the hip, but a good attitude and the proper exercise made a big difference in the success of the replacement operation.
Last October, I had my second hip replaced. Went just as smooth as could be. Within a couple weeks, I went back for a checkup, have the staples removed, and I was able to walk in on my own. Felt really good about it. I was in no pain. They took care of the staples, and they had me walk back and forth. They watched my gait, made sure that I was level and everything was coming right along, and it truly was. Felt very good. At the same time I was there at the clinic, the people that also had their hip replaced at the same time were there and came in various ways. Wheelchair, cane, crutches, but I was able to walk on my own and without any difficulty. He was very pleased. He commented that my recovery was excellent. But a lot of that had to do with the fact that I was active prior to surgery. I wasn't sedate. I wasn't sitting around and feeling sorry for myself. Yes, it hurt. Yes, it hurt a lot. You got to use the muscles. If you don't use them, they're gone. And I don't care if that's with your normal routine of your housework, vacuuming. I was very fortunate to have a job where I was sitting at a desk and I had the freedom to get up and do things. So I wasn't just sitting, I wasn't just standing, I wasn't just walking. I was doing a combination of everything. The constant up and down is what you need to do. It hurts, and you got to try to control it. You can't plop in the chair. You got to use those muscles. But now that I'm retired, I go to the pool at least 3 times a week. I try to get there, and I really work out though. I do the jumping jacks and kicks, and I really work hard, and I can feel it when I'm done. I mean, I push a lot. So it all had to do with keeping active, doing your exercises prior to surgery, and then of course doing your exercises afterwards, and get up and get going. And that was it, yeah.
Hey, call in your questions about anything, bones and joints at 1-888-376-6225, 1-888-376-6225, or email us on ask@oncalltv.org. So, Jim, she made a point. I loved what she said, because she talked about being in shape before the surgery and then all that exercise afterwards. What's your feeling about that value?
I think that doing that surgery exercise is really important. If you think about it, for example, a total knee or a total hip, you've put up with that, and the function's deteriorated over a long period of time. And so all those muscles and those tissues in there, they have changed dramatically, okay? And if you think that you could just go in there and cut that piece of bone out and stick a new joint in there, and then you're going to heal up and that thing's going to move fine.
You don't have the muscles working.
You don't have the muscles. So now you have to rehabilitate all the muscles as well as get that joint mobility. So what I like to have people do, like before a total knee or whatever, is to maybe even see a physical therapist. Get on some exercises. Do it. Do the straight leg raising, the quad strength. You don't have to go. You can't walk, or if you could, you wouldn't be having your knee done.
Right.
But do the basic exercises to try to get things stretched out, get them going. And the other thing is, be sure that you go over your medications before you have that surgery, so the medicines can be changed properly. There are medications that should be stopped during the time of surgery, some that shouldn't be restarted until you're off the blood thinner after surgery. There's just a lot of different things, and sometimes people overlook that and they think, well, gee, I'm just going to go and have that surgery, and they forget to go through all the meds, so that's an important thing too.
So you see a lot of people who have surgery, knees and hips and back surgery. Yeah. Any comments about back surgery that you'd like to make sure that people remember?
Too much of it.
Too much of it?
Too much of it. Yeah, I think that people think, they got a backache and they're tired of the backache, and gee, I'll just go get it fixed. It doesn't work like that. If you're operating for a backache, most of the time you're going to have more backaches. And if you have an actual pinching of the nerve, something going wrong with the nerve, you have something that's not right there with the disc or whatever, then obviously the surgery is a hugely important treatment. But I think people somehow get the idea that, well, gee, maybe I can just get that fixed and I'll have a normal back again, and it just doesn't work out that way,
We've got on the telestrator a drawing of normal spine and a curvature spine, osteoporosis, and you see people with collapsed vertebrae, and they're doing these vertebrae plasty type of things.
Vertebroplasties,
yeah.
Right.
What's your comment about that kind of procedure and the osteoarthritis that occurs in backs? Because you can sure see a lot of it on the MRIs.
It's complicated. You get the degenerative changes around the joints, the little joints in the back. You get those degenerative changes, and you can get an X-ray and you say, gee, your back is full of arthritis. Well, it's not. It's full of bone spurs and it's full of this, that. It's not really full of arthritis in the sense that, gee, there's this hugely active disease that we have to go after. It's just basically bone spurs back there. Where you get into problems is when that process starts to encroach on the spinal cord or on the nerves, or the nerves exiting and exiting going to your extremities. That's where you get problems, and that's where surgery comes in. Just having a backache, I'm a believer in just using the proper analgesics, the proper physical therapy. If you could get people just to do the therapy, they go and they see the therapist and they get the exercise and and everything's going well, but then a year later they're not doing the exercises, and their back still hurts, and so, well, maybe I can get this fixed, and
surgery.
And the surgeons are trying to help you. They're trying to get you better. They say, well, I see something wrong there. If I fix that, maybe you'll be better. And
it's not really great for pain. It's good when you're losing nerve function and your foot's starting to drop, or there's some neurologic changes. But for pain, it doesn't work well. We have from Dakota City, Nebraska. How important is the IgG rating for immunity? I'm in the 500 range.
Well, the IgG is just one of the immunoglobulins, and so you get you can have immune deficiencies, so they're more prone to get infections. You can have an overproduction of them. You can have vastly overproduction that can be myeloma. Okay, you can have an active overproduction. So it really has to be in the context. You can't look at that number and say, well, gee, this number is X, therefore Y and Z will happen. It doesn't work like that.
way.
You need to know, A through U, and then I can tell you what VWXYZ will happen.
Yeah.
Okay.
So it's so clinically tied. I mean, there is not a X-ray or a lab test that does it. It's the knowledge of the clinical putting it all
If
together.
it did, I mean, if it made just think about it. If that made a critical difference, okay, if that was really a key thing in terms of how you're going to live your life and what diseases you're going to get, then we should have a screening clinic in every mall and check an IgG level or an immunoglobulin on everybody, because if it's that, and it's not.
It doesn't work that way.
It doesn't
It's sort of like a screening test for cancer, a blood test for cancer, you know, a CE. A painful knee, will copper sock cure it? Will I need to replace the knee? So let's talk about copper. There's a ton of copper out there. What
Now,
are-
let's talk about it very briefly, because
Okay.
it's all placebo. Okay, it was studied, you know, Kennecott Copper Company back in Utah, you know, 50 years ago thought, well, maybe we're onto something here with copper. They did studies with placebo copper and everything like that. It's basically placebo. So yeah, you can wear
It's the
copper,
same.
you know, and you can, if you can put up with the green skin that you get from wearing a copper, that's fine. But that's all it is. It's placebo.
It's chondrocalcinosis, best way to treat besides cortisone shots.
Tough one. Chondrocalcinosis is the cartilage deposit in the you get the calcium deposit in the cartilage, or calcium, particularly tiny calcium crystal in the cartilage. It can sometimes reflect other diseases, so you have to sort of make sure you don't have some other endocrine problem or a hemoglobin problem or something like that. But most of the time, you don't, and you just have it there. And what happens is you get this little bit of calcium crystal that flicks off, and it causes inflammation and deterioration and everything. And there really, right now, is not a good treatment for it except for anti-inflammatories. The little stronger anti-inflammatory, of course, would be the steroid, and you put a steroid shot in there.
Do you inject a lot of these or whatever? With
I grew up in a time where injecting joints was the last resort before surgery, and we were taught that you don't stick needles in things because bad things can happen, and so
You're conservative.
So I'm very conservative in doing it. The young people being trained today are much more aggressive with their ultrasound. They can see the ultrasound is wonderful. You can see what you're doing. You can see where the needle is, all that kind of stuff. But yeah, I've done lots and lots of joints over the years. But you got to choose your battles there, I guess.
Right. All right. You've heard us say it often on this show, what you eat can make a difference in your health. Our dietitian, Katie Vanderwall, shows us an easy and tasty way to help meet your calcium needs for a healthy life.
Calcium and vitamin D are an essential part of your diet, along with living a healthy lifestyle that includes exercise, including weight-bearing exercise, will help prevent osteoporosis. Calcium needs are highest during the adolescent years when bones are beginning to form and are absorbing the most amount of calcium. Adolescents need an estimated amount of 1,100 to 1,200 milligrams of calcium daily. Calcium needs again peak later in life, about the age 50 to 70 years, because that is when bones typically begin to lose calcium. And at that time, calcium needs are estimated at about 1,000 to 1,200 milligrams of calcium a day. Consuming foods high in calcium will be important. Foods high in calcium can include dairy products, fortified grains, along with some common fruits and vegetables, and dried beans that we might eat on a daily basis. Obtaining adequate amounts of vitamin D will help your body absorb the calcium that you're consuming. That can be obtained simply from the sunlight or from fruits and vegetables as well. For breakfast, you can start with a simple yogurt parfait. Yogurt is going to be a food high in calcium. Adding kiwi, which is also a fruit that is high in calcium, to the top, and a sprinkle of homemade granola, which contains oats, which is a high calcium food, will give you a high calcium breakfast to start your day, or a snack for the middle part of the day. For an easy noon or evening meal, high in calcium, baking or steaming a piece of salmon, adding a sweet potato of the appropriate portion size, and also adding broccoli with a sprinkle of cheese to add even more calcium to your diet.
I love that. Katie, thank you so much for that. Now, this was showing calcium in your diet. What about calcium supplements? Forget the diet, just eat calcium tablets.
I think that getting it from a diet is a much better way to get calcium than the pills. Okay, the pills, sometimes there's always debate. Do you take it before you eat? Do you take it after you eat? Do they dissolve? Do they not dissolve? Are they coated? They're not coated, or whatever. And I think that you tend to overdo the calcium sometimes. Okay, I mean you tend to. I think there have been studies that show people get too much calcium and they start,
Calcifying
bad
your
things
arteries.
can happen with calcium in your body.
Heart
So you don't. So you figure out kind of where you need to be. 10, 11, 1,200, and then figure out how to get it in your diet. Supplement it with a Tums if you have to once in a while, and that's fine. Make sure you get your vitamin D, okay? And then
You go 2,000 a day, or what is
well, I think in the winter months, 2,000 a day is probably reasonable. It's probably overkill. It's probably a little bit more than you need,
But not dangerous.
at our latitude, in the winter months when we don't get much sunshine, the summertime I'm not so concerned about. If you're getting out and getting some sunshine, you're getting plenty of vitamin D. But from October till March, you should take a supplement, I think. Yeah.
I believe that the best multiple vitamin is a balanced diet. So let's hit some questions. We're getting plenty of questions. Brandon, talk about polymyalgia rheumatica. What treatments are out there, and wants to know more about PMR?
Polymyalgia rheumatica, or PMR, is another immunologically mediated rheumatic inflammatory disease that tends to be manifest mostly as muscle stiffness, okay, or muscle pain, very often around the shoulder joints. So people feel it up here, occasionally in the hips, but mostly up in here. There is probably some inflammation in the shoulder joint itself, but the main symptom people have is this incredible stiffness they develop. Generally older people, generally over in their 60s or older. Most of the people that I see with new onset polymyalgia are probably in their 70s. You can check inflammatory markers that can tell you in the blood that yes, we have inflammation, and then the treatment is prednisone or cortisone, and the real clincher is when you give somebody that prednisone, and literally within hours the stiffness is gone. Yeah. And it's small doses of prednisone.
5 milligrams.
I give you a big dose of. I can make anybody feel good. Give them a big dose of prednisone, but give them 5 or 10 milligrams and they feel better. You're onto something.
Degenerative hip arthritis, anything new, any alternative to surgery, stem cells? We're not there yet.
Not there yet. No.
Stem cells
I think that cartilage transplants will be where
Something.
that's, yeah.
All right. Brookings, osteoarthritis, what to do if you can't take anti-inflammatory drugs. A lot of people can't tolerate non-steroidal anti-inflammatory drugs. I know you use a fair amount. You would prescribe a lot. A lot of people do well on ibuprofen, Aleve.
Yeah. Keep in mind that, again, I started this business in rheumatology when that's all we had.
Yeah.
Okay? I mean, that was it. You basically gave people, so you learned how to give people anti-inflammatory medications, and I think that we've done a pretty good job of that over the years. If you just absolutely can't take an anti-inflammatory medicine, then you're just stuck with analgesics.
Caller has a salt taste in her mouth while taking glucosamine. What causes it, and what can she do to prevent it?
Probably nothing, and it's, glucosamine is one of those sort of, it's out there. There probably are some people that respond to glucosamine and chondroitin. It's the small number, though. It's not going to work for most people, and it's probably worth a try. But if you're getting, it's probably something with the glucosamine sulfate.
Dump it.
They do make a glucosamine sulfate, and they make a there's 2 different salts.
Yeah.
One's a sulfate and one's hydrochloride.
Try the other
And
one.
you could try the other one.
Has MS and osteoarthritis and rheumatoid arthritis. What can she do if she's allergic to methotrexate?
Well, there are a lot of good things to do, but here's an interesting point that raises. These diseases are not mutually exclusive, okay? I have people who have rheumatoid arthritis who can still develop degenerative arthritis, or people who have degenerative arthritis and all of a sudden they've got lupus, or they've got, I mean, or PMR or whatever.
You can have more than one.
You can have more than one, okay? And this is not like, oh, gee, mine is osteoarthritis, there I am for the rest of my, no, you got, other things can happen too.
Keep your ear.
This situation, if somebody can't take methotrexate, okay, there are really, really good alternatives out there. Another one that's very inexpensive, that's sort of been in the shadow of all the big ones is Areva, leflunomide, which works in a system similar to what methotrexate does. But it came out and it was just getting traction when all of the biologics came out.
How much does that cost a month?
Oh, cheap, generic. $4 at Walmart.
Oh, really? Arava.
Leflunomide.
Leflunomide.
That's the generic name.
What anti-inflammatory meds are used for osteo? We've talked about that. Ibuprofen, Mobic, naproxen.
Meloxicam, that's generic.
Yeah. What else?
Celebrex is the one that's left on the brand, and
Yeah.
you know, it's
It's soon going to go generic.
soon. Yeah.
Caller has sciatic nerve damage, spinal stenosis. What can she do for
Okay,
this?
now that's a different thing. There's a surgical situation probably. And once you get spinal stenosis, what's happened is that things are encroaching on
Right.
those nerves, okay?
Right.
And the more they encroach, the more the nerves don't work. You get numbness, dysfunction in your lower extremities, and something's got to be opened up there to get that opened up, okay?
Right.
And so that's a situation where you,
needs to
that you talk to a surgeon about that one.
The caller wants to know about lupus. What other illnesses are associated with it or related to lupus? And I'm thinking scleroderma, Crest syndrome.
All of those autoimmune diseases sort of run in a pack together, okay? I mean, you have rheumatoid overlap with lupus, and you've got scleroderma that's got lupus kind of things going on with it, and you've got other vasculitis things that can have this variation, and so they're all kind of, there's limited lupus, there's diffuse lupus, there's all kinds of
Discoid
variations.
lupus.
Discoid, just in the skin. I mean, it's hard to get at what the questioner would like to know there.
Let's talk a little bit about gout. This is a 25-year-old guy, swelling in the right knee, difficulty walking, severe pain, MRI shows swelling, synovial fluid, had lots of fluid removed, no crystals, but high levels of nucleated cells. Uric acid is normal. Love to get back to basketball and other exercises. He probably doesn't have gout, but
Could have, but unlikely. If he's got, if when the dust settled and he was not inflamed or anything like that, and you check, that's the critical time to check your uric acid. You don't check your uric acid when you're having a gout attack, okay? Because
things can change.
gout attacks can come from either bumping up the uric acid in your system or dropping it. And if it happens to come from dropping it for some reason, you get the attack, they draw your blood, they say, oh, gee, it's normal. You need to know what your uric acid is when everything else is normal. That's number one. Number two, the nucleated cells are white cells. That just tells you got a lot of inflammation in there, okay?
Yep.
And then three is, you need to be sure that the people looking for the crystals knew what they were looking for.
Yeah, I bet it's gout. So tell me about this fork thing. I mean, what is that?
This is a lapel pin. I didn't want to blind anybody wearing it, but this is the American College of Rheumatology. My
club.
organization has started a campaign called the Simple Tasks campaign, and it is, it's interesting. If you wear this lapel pin and you get on the airplane or you travel someplace, I mean, people, it doesn't take very long. They say, what is that bent up fork? What is that?
Yeah.
And so it starts the conversation. Do you know what a rheumatologist is? I mean, I want every cab driver that I get into a cab with or whatever, if I say, what's a rheumatologist? I want them to know what a rheumatologist is. But anyway, Simple Tasks is to demonstrate to people that a rheumatic disease can change very simple functions like eating with a fork. And there's a website that the American College of Rheumatology has put together called simpletasks.org. I think we're going to put it up.
Yeah, I think it's
Simple
up.
Tasks. And I'm going to put this down right now. But simpletasks.org is an entree to all kinds of good information, okay? Whether you want to know about juvenile arthritis or you want to know about rheumatoid or drugs, and there's linked to the American College of Rheumatology. There's other important links that are in there, and it's not commercial, it's not selling anything,
Right.
It is just good bona fide information. But, think of that bent up fork and how rheumatic disease can wreck Simple Tasks, okay?
So you've got a minute before we're finished with our chance to interview. Do you want any take-home messages you want to make sure that people would have?
Take-home message would be I think that arthritis things are important to be sorted out. We have rheumatologists now on both ends of the state that can help your primary care doctor sort things out. And I think that it's important to get to the right answers, get the right treatments. You shouldn't be unnecessarily depressed if you're diagnosed with one of these things because we have really good treatments out there. You just got to get on top of it and get after it. And then, just to kind of circle back to the research thing, we are just, even this week, starting a research study on what we call biosimilars, where we have Remicade-like drugs now
Yeah.
that we have a study going on. So if you have rheumatoid arthritis on methotrexate and you're not doing so well, we're starting a study on a similar drug to Remicade. These things are available, and you know, if you're so inclined, you can participate in studies like that. So
Call
you know,
one of the systems and ask.
right.
We'll be back right after this.
The flu bug is getting ready for another season. Are you? Get vaccinated because stopping the flu starts with you.
The 10-year-old came into the walk-in clinic with a sore throat, but no cold, runny nose, or cough. Her mama said she had a fever of 101, and her knees, elbows, wrists, and ankles were hurting. To top it off, she had been acting unusual, having quick, uncoordinated jerking movements, having emotional outbursts, and laughing when nothing was funny. There was a rash over her abdomen and back, and upon listening to the heart, a murmur and an unusual scratchy rubbing sound was heard. Her neck lymph nodes were large and tender, her throat was red, and her tongue had a strawberry character to it. The throat swab was positive for a specific Streptococcus bacteria, and a blood antibody test called an ASO was also positive for strep, indicating an immune reaction was happening against that bacteria. Her immune system was attacking her own joints, her heart, and even parts of her brain in a misdirected effort to fight that bacteria. In the 1800s, rheumatic fever, then called acute rheumatism, was thought to be the same process as rheumatoid arthritis, then called chronic rheumatism. In the early 1900s, experts believed that both diseases were the result of a bacterial infection. It was discovered later that rheumatic fever is an infection-induced, immune-driven condition, and that rheumatoid arthritis is not related to a bacterial infection at all. Rheumatic fever can occur in children ages 5 to 15 years of age, 2 to 4 weeks after a strep infection of the throat. The diagnosis is made when 2 of the following symptoms occur: large joint pain, signs of heart inflammation with a new murmur, nodules under the skin, a specific marginating rash, and neurologic changes of emotional instability, weakness, and jerky movements. The diagnosis of rheumatic fever mostly comes from taking a careful history and providing a thorough physical exam. Laboratory and X-ray testing is important, but only supportive. It's interesting to know that a strep throat infection doesn't get better any faster with antibiotics. It's a self-limited condition which will resolve over several days or so with or without the antibiotic. The reason treatment is given is to prevent rheumatic fever, and especially the heart valve destruction that it can cause. This is still done even though rheumatic fever has become a rarity, likely the result of the widespread use of antibiotics. The 10-year-old girl was treated with amoxicillin, ibuprofen, and she got better. Jim, we've got 1 minute. What about rheumatic fever? Have you been seeing that?
We don't see so much rheumatic fever anymore with the antibiotics and.
Yeah, we don't know. Well, this brings us to the end of our show this evening. I sincerely thank our fantastic guest, Dr. Jim Engelbrecht. As often happens on the show, time ran out and we didn't get to all of your questions. So to hear our answers, please join us now on our website, oncalltv.org, where you will continue live with On Call After Hours on the web in just a few minutes. Singer Reba McEntire knows firsthand that to succeed in life, you need 3 things: a wishbone, a backbone, and a funny bone. And until next time, stay healthy out there, people.
Diseases we thought were gone forever are reappearing in areas where parents are deciding not to vaccinate their children. Is there a good reason to resist inoculations? Or are you just putting your children and neighbors at risk? Vaccines, do they work? Do they hurt? Next time on Call with the Prairie Doc.
Hello and welcome to On Call After Hours, where we answer the questions we weren't able to get to during the broadcast portion of our show, and we've got a bunch of questions. All of your questions are important to us, and we want to answer as many as we can get to, so let's get going. Here, what is the best natural anti-inflammatory? I mean, oil of wintergreen was the first aspirin. I mean, do you have a natural anti-inflammatory? Or just say what you really think.
Yeah, I don't know of any really that you could take in a way. Fish oil, okay, gets into the anti-inflammatory. But the blood thinning is first with fish oil. I mean, that's and you got to take a lot of it. So it's just really there's not a good food substance that I can tell you that would be a good anti-inflammatory. Now, there are some herbs and spices and like ginger and some of those different things and that have been touted to be helpful, and maybe they are, but they've never really been studied.
Okay. 15 to 20% at risk for muscle problems when taking statins. Is there a test one could take before to determine risk, like a DNA profile?
Nope. You just basically, you take it, but you just have to be aware of that's a symptom. But if you start getting, unusual stiffness,
that you just stop.
Then you stop it, and and the quicker you stop it, the quicker it'll go away. I've had people that put up with it. It's sort of mild, and they get sent to me after they've been on the statin for a year, and I take them off the statin, and 3 months later they're fine.
Yeah, I've heard there's genetic testing for statin as far as one is more efficacy and.
Yeah, I don't know.
Are you willing to take a quick survey that? Osteoarthritis, does taking Celebrex or Enbrel daily help?
Yes. No, well, Celebrex.
Celebrex daily helps, yes. What is Enbrel?
Enbrel is for rheumatoid arthritis.
Does it help osteoarthritis?
No, not at all.
Not
but
at all.
Celebrex, if you have enough deterioration of the bone that you're causing continual inflammation, you will do better if you take an anti-inflammatory on a regular basis. So Celebrex once or twice a day will give you what you need, because it basically analgesics work up here, the anti-inflammatories work in the joint, and you got to take enough of it to get into the joint so that it can work, and that means taking it every day.
Yeah. All right, that's an important issue, although you have to also monitor blood pressure, monitor fluid retention, renal function.
You have to have a talk with the patient before they take these on a regular basis, okay? First of all, it's age. It's different if I'm talking to a 40-year-old than I'm talking to a 70-year-old, okay? These are the things I'm concerned about. This is what I'm going to check in your blood. This is what I want you to watch for. If you get this, or this, I want you to stop it immediately and call us.
Hip Winter, South Dakota. What is your opinion of a hip replacement for someone over 90? It's a great question.
It depends on, if they are 90 years old, but physiologically 80 years old, I'd say go for it. If it's a young 90 and you've got all your faculties and you can do the stuff, I would go for it.
I'll
tell you a little side story. Since I've been in South Dakota, the guy that was the oldest that ever got knee replacements, he had one knee done when he was 92 or 93, and the other one done when he was 94, and he lived to be 98, and he never regretted a day that he had those done. And he was a rancher out there in the middle of nowhere in South Dakota, and he wanted to tromp around out there with his cattle, and he did.
Is homeopathy an approach used with arthritis due to an autoimmune disease? Is it something to use? Homeopathy. What is it, and what do you think?
I know a little bit about homeopathy. Where you basically take little tiny doses of some things and dilute them out, and I just never really put too much stock in it, and I didn't really follow it. And I know what it is, but I don't know anything about it.
All right. Aberdeen, is arthritis related to allergies or chemical exposure, and what against are or are not working to cause arthritis? could chemical exposure cause arthritis? Is allergies a cause of arthritis?
Well,
And what organs are or not?
chemical exposure, you know, I'll tell you one substance you can get exposed to is silica, and it can cause scleroderma-like illness. Okay, and that used to be the hard rock miners and some of this, you know, some of that stuff. So there is some precedent for those kinds of things. Now, you know, there's talk about, you know, polyvinyl chloride and some of those things, whether they could create similar things. I think they can create a scleroderma-like thing, but there's really, these are really out on the fringe. Okay, I mean the mainstream stuff, it's just, you know, we don't know. I mean, there's no specific thing we can point to.
Is there a better medicine than Voltaren for osteoarthritis? It causes stomach bleeding. Voltaren, do you use that?
Well, yeah, I use Voltaren, but you know, again, there are probably, you know, I guess depending on how you split it, probably close to 30 non-steroidal anti-inflammatories right now. And so we will use things like, I mean, the simple things that you can buy over the counter, ibuprofen or naproxen, meloxicam, Celebrex, Voltaren. I mean, what used to be called Lodine, Etodolac.
Yeah.
I mean, there are a lot of them out there to try. Okay, and so Voltaren, if somebody was really getting a good effect from Voltaren, but they were getting stomach upset or they were anything like that, then I might try a different drug that's in this similar category. You know, diclofenac is Voltaren. Etodolac is a different one. And sometimes if you just change the chemical a little bit, you get the effect and not the side effects.
What about topicals? I know that there's a whole thing about people using Voltaren topical over joint problem. Have you been doing any of that?
Yeah, there again, if you're, you know, the patients that I deal with have things going on everywhere. So I mean, you'd have to bathe in this stuff, okay?
Yeah.
But
it takes a lot.
you know, if you use if you have breakthrough areas, okay, if you're otherwise healthy and you overdo something in your shoulder, you know, put the roof on your garage over the weekend or something like that, and the Voltaren gel would be terrific for something like that. But so will time and heat, okay? But you know, so that would be something. If I have somebody that has rheumatoid or osteoarthritis and they really do pretty well, but they get breakthrough pain in some area, I'll use something like a Voltaren gel.
What is the connection between neuropathy and lupus?
It's the fact is that the antibodies or the immunologic dysfunction in lupus can actually attack different aspects of the nerve. It can get to the blood supply of the nerve and knock a nerve out. It can actually attack the nerve cell itself, or a combination of those things. And so you can see everything from stroke-like symptoms to what's called motoneuritis multiplex, where it's just like cutting the nerve here and all of a sudden you got numb
hand,
or
dysfunctional hand.
Right. And so, and it's just, you know, that's fortunately is rare in lupus, okay? It's in the single digit to maybe 10% at most group. But yeah, it's something got to be aware of. I've seen it. I've only seen it a couple. You know, I've seen really dramatic cases like that probably on 2, 3, 4 times, maybe in 35 years. So.
2 hip replacements, skin and cold and numb around the area of the cut. Is that a common deal?
Yeah.
Yeah.
Anytime you cut those nerves, and it takes a year for those nerves to regenerate, even if they can regenerate sometimes.
Gout versus rheumatoid arthritis. What's the difference?
Well, you know, you can get gout that's bad enough that it hits lots of joints and it can be mistaken for rheumatoid. And I've seen that. People get sent to me for rheumatoid arthritis, and lo and behold, it's gout. And it's polyarticular gout. In other words, it means many joints. But typically, the typical gout will start with an attack in one joint, like the big toe or an ankle or a knee or something like that, where it's just one. Where rheumatoid tends to be a much more diffuse process, symmetric, small joint, that kind of thing.
One's totally crystal and one's totally immune.
Right.
What about this one from a smaller community in South Dakota? Comments on illnesses in correlation to a change in the food supply over the years. Do you think that the way we eat nowadays has anything to do with arthritis of any kind? You didn't jump on the hygiene idea as much as the allergists.
I mean, I'm just not. You know, a lot of this is conjecture, and I just, you know, you hear this little bit, but I've not seen any good science on that.
Okay. What can you do about arthritis in your feet and ankles?
Again, the first question, is what kind of arthritis is it, okay?
Yeah.
And if it's degenerative, that's a whole different thing in the ankles and feet. The ankles typically don't get degenerative arthritis. The feet can very typically get degenerative arthritis. So it's more, is this arthritis? If it is, what kind of arthritis is it? And what is, then how do I approach it?
Why is exercise so important for those who have lupus or arthritis?
Well, for the same reason it's important for everybody. You have to keep these tissues moving. The thing is, you have to exercise differently. Okay, you're not going. If you're a lupus patient with inflammation on these medications, and you're going to train for the Boston Marathon, I'm sorry, it ain't going to work. Okay, but if you're going to tell me I'm going to go out and walk 20 minutes 4 or 5 times a week, or I'm going to go on the stationary bike and pedal, 15 minutes twice a day for 3 or 4 times a week, it'll work just fine, and it keeps things,
From Watertown, once treated for polymyalgia rheumatica, does it lead to a digestive problem and touch on juvenile arthritis?
Digestive.
Yeah, digestive problem.
Because you got to use the steroids, so sometimes you could probably
Get upset stomach.
get upset something from that or everything. But usually, the treatment of polymyalgia rheumatica, you finish. It usually takes about 2 years. I mean, the disease process. If you look at the natural history of polymyalgia rheumatica prior to having steroids, what happened to these people?
Yeah.
20% of them died, and 80% of them got better over 2 or 3 years, and with some limitations. Sometimes they had atrophy, they hadn't used things, they had limitations, and so the steroid changed all that. But then the steroid could have side effects, but we know the natural history of the disease, in most cases, is about 2 years. So when I make the diagnosis, I tell people, prepare to take this medication for the next couple of years. But what we're going to do is we're going to gradually diminish the dose. And with prednisone, the less you take, the less the side effects are, the less the problems are.
So we've got a lot more. So let's be really fast.
Okay.
How much should someone in a sling post-shoulder surgery move their arm to keep healing correctly?
Whatever the therapist tells them to do. That's the key.
Hammer toes and seroma, is there an injection that would help avoid surgery?
A neuroma, you can inject and try that. Hammer toes need surgery.
Total knee June 23rd still makes clunk noise. How do you stop the noise, and does it mean something's wrong?
Talk to the
surgeon.
orthopedic surgeon. Okay, I tell people after surgery that they really need. They can do a lot of things in a couple of months, but it's really not their knee for 6 months to a year. So you can have all kinds of funny things go on.
Bad hands, wrists, huge bump under hand, below thumb on the wrist, cortisone shot and wears splints. And I think there's a lot about thumbs. Talk us about those.
The joint where the thumb comes together with the wrist, okay?
Right.
Which is called the first metacarpal carpal joint. So
Right.
it's right,
In that snuff box.
the anatomic snuff box, okay? Right there, where your thumb and your wrist come together. That's a very common place to get degenerative arthritis. And sometimes splinting will help that. Sometimes anti-inflammatory, sometimes heat, sometimes a topical Voltaren will help that. Sometimes a shot of steroid will help that. But if all that fails, there's a really, really good surgery where they go in there and take that out, and they can actually make a little artificial joint out of it, some tendon material in there, so you're using all your own tissues. A good hand surgeon could do that. I mean, you don't want just anybody doing that. You want to go to a hand surgeon, but that's a really good operation.
Amyloidosis, medications lower immunity. Why you must lower immune system? More genetic information on amyloidosis. Any comment?
Amyloid is one of those kind of difficult diseases because amyloid can occur as a primary process. It can, you can just all of a sudden get these funny protein things being produced that they're glomming together and sort of causing damage to organ systems. You can get it related to myeloma because of the proteins that are being produced. And then there's the secondary or so-called AA amyloidosis, which comes from chronic inflammation. So we see, we worry about kids that have chronic juvenile arthritis, after 20 years, are they going to have amyloid? Haven't seen a lot of that, but it's out there. But it's difficult because there's not much, there's not much to do.
Yeah. Quick carrying extra weight, is that hard on your arthritis?
You know, it I don't know how much the extra weight is, but it probably is. But if you have, if obesity has also a metabolic effect, and it changes the metabolism of the tissues, including your joint tissues. So if you look at people that have obesity, you'll find degenerative changes that are worse in non-weight-bearing joints. So it can't just be gravity.
Something else is happening.
Yeah.
Mitchell, how do you know when to replace a knee or hip? Any criteria? That's a tough one that orthopedists have to wrestle with.
Well, and it's just, you know, I'll see somebody and I'll get an X-ray of their knee and it looks terrible and they don't want that, and they're fine. They put up with it. They don't, you know, they want it. And I have somebody else, they can't hardly walk, and you X-ray the knee, and why are they having all this pain? So it's really, if you've got degenerative changes, it really depends on how much function you're losing, how much pain you're having. You should always, in my estimation, early on work with a physical therapist, because there's lots of, I mean, physical therapy is just incredibly important in all this stuff.
That's a big take-home right there, I think. Ankle replacement surgery, you have any opinions like that?
Yeah, you know, it's there. It's not been as tried and true as hips and knees, but for the right cases, it's very helpful.
Dr. Oz said that high doses of pain medications over a number of years will stop working and cause more pain.
Well, I think you know, again, the complicated issue, but you know, with narcotics, for example, the more you take, the more you need, and the more they don't work, and then the more you need, and that you get into that cycle. I don't know about causing pain actually, but it's, you know, I think that's probably something along those lines.
There's some non-steroidal induced headaches that people have. That 77-year-old will get metal hips last May until, will my metal hips last me till I die? They're 10 years old. She's 77. How long do metal hips?
You know,
depends upon how active, huh?
Well, no, it just, you know, I mean, it's just, it's different things work differently on different people. I mean, I've seen people who are, I mean, hard to believe, but I've seen people 30 years out on total knees, okay? And I have some people have them redone at 8 or 9 years. So
Yeah.
it's just,
Who knows?
who knows?
Here's one. What the side effects on the lungs using gold shots? Now, you've probably given, I mean, I used to give gold shots.
Yeah, no, I did. I mean, that's why when I
A lot of lung
the
problems?
fellows, when we were in training, we did the gold clinic.
Yeah.
I mean, every week we did gold shots. So, and the problems?
Yeah, side effects.
Oh, you know, the
Lungs?
problems, the problem, no, there's not a, you know,
Methotrexate will give you one.
there's a low chance of a methotrexate reaction, I suppose, with gold. I don't remember that right now, but there was what was it called? You know, there is gold toxicity. You can give somebody too much gold and they get too much gold in their tissues and stuff like that. It's called
They get a neuropathy? Heavy metal.
chrysiasis or something like that.
Yeah,
It's
yeah.
like something like that, yeah.
It's, they Midas touch, you turn into gold and you freeze, you know, you're dead.
Something like that.
Neck pain, crunches when she turns her neck, goes down to the shoulders. Does this have to do with her osteoporosis? You run into a lot of neck pain.
Yeah, but it's it's more like osteoarthritis. Okay, it's osteoarthritis in the neck, and again, an evaluation. But oftentimes, if it's early, it can be really symptomatic. But if you get some physical therapy, it can really make a difference.
All right, I've got some. How about cannabis oil? Does it help arthritis?
Don't know.
Don't know. Don't remember. Just a joke. How does the doctors?
No, but it makes you hungry.
Yeah.
Yep.
How does the doctors feel about? How do they feel about turmeric concentrated, cherry juice, or holistic treatments for arthritis?
Well, you know, turmeric gets some play in terms of it. You know, there's some effect there. I don't know anything about that. That cherry juice and gout is the what, you know. There's something about cherry juice, and it doesn't have to do with uric acid or it's just something. There's something anti-inflammatory with regard to that crystal-induced thing. Something with the cherry juice that seems to be there. So
Maybe.
You know, it certainly tastes good.
For bow-legged, what's the best option for fixing this? Would knee replacement work? Hurts bad in knees and hips. I would say yes, don't you?
Yeah, you know,
Bow-legged.
that's a big, but you know, once you get that deformity, that's the one thing the surgery will do is straighten that out a little bit.
We haven't talked ankylosing spondylitis. This treatment, TMF blockers, suggest for sinus infections.
TNF, yeah, TNF.
TNF.
For ankylosing spondylitis, it's very helpful, very good. You know, ankylosing spondylitis is, you know, it's one of the first genetically identified, and even there, even with the HLA-B27, it's not an absolute, okay? Normal
Right.
population, 12% of people have HLA-B27, never have spondylitis, okay?
Yeah.
Just because 90% of people with spondylitis have HLA-B27, you can't screen the population for this. But anyway, in the bad cases where it's really aggressive, and not only in the sacroiliac joints, but in the lumbar spine, thoracic spine, extra-articular things in the eyes, you need to use stronger medicines, and the anti-TNF drugs like Humira and Enbrel, Remicade really have been fantastic on that.
Really have helped.
Right.
I have arthritis but no pain. Does not want to operate because no pain, but I can't walk well. What do you think about
Physical therapy.
that? Physical therapy. 2 questions left. Suggestions for therapy for psoriatic arthritis for someone with liver disease.
Psoriatic arthritis, there's several different kinds. If you have the most common kind and a lot of plaque psoriasis and you have liver disease, I would go with the anti-TNF drugs as monotherapy. I wouldn't worry about the methotrexate or the other drugs that could hurt the liver. I'd go right to the Humira, Enbrel.
And they're not so hard on the liver. No. But the methotrexate can be.
Methotrexate can, yeah. You know, if you have somebody with serious liver compromise, you've got a whole different issue with methotrexate. I'd be very hesitant to use it there. Just, you know, there's always exceptions, but as a general rule, I wouldn't want to use it.
So the last one is about back pain. Hurt his back 14 years ago, stress fracture, bulging discs, lots of physical therapy, lots of pain that never goes away. I'm 71, a lot of deterioration in the top and bottom of my back and arthritis. What helps? I try to stay active as I can. I do not take any meds for this because I'm sensitive to a lot of meds. You know, what would you recommend for this person who wants to be active, doesn't want to take meds, has had chronic back pain?
Well, you know, there is a situation where we really do need to talk to a spine surgeon and see exactly what the problem is and how much instability is there. You know, you can get some instability in an area that you could fix by fusing it.
Right.
But typically, you'll get something besides a backache. You'll have some kind of symptoms that go down to the lower extremities. So it's a tough call to know what to do for that. Sometimes bracing will help, something, you know, but it's
a tough issue.
It's a tough issue.
So what a burden of work that you've piled through, and you know, wonderful information for people. I so much appreciate it. Any take-home things that you wanted to make sure?
Well, I think it's you know, there are a lot of things that we didn't touch on, and we'll do next time.
We'll do her next time. Thank you so much.
All right.
Thank you for joining us on our website. We appreciate all your questions and the opportunity to answer them. Be sure to join us next week on South Dakota Public Broadcasting at our regular time, and call in or email your questions. Also watch for our column in your local newspapers. Listen to our Prairie Doc Conversations radio show on a station near you, and like or follow us on Facebook, Twitter, and Pinterest. And until next time, stay healthy out there, people.
Funding for On Call with Prairie Doc is provided in part by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota. Additional funding is provided by Aberdeen Asthma and Allergy, Brookings Health System, Dr. Mark Bubak with Dakota Allergy and Asthma, Dakota Care, Dakota Dermatology, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, and Swiftel Communications. Closed captioning for On Call with Prairie Doc is provided by the generous support of Avera, Brookings Health System, and Fishback Financial Corporation.